So it's my privilege to introduce yet another graduating chief resident who has been with us now a long period of time. It's not quite a decade with, in our department, but it gets pretty close for many people. Kyle is an Eagle Scout who hails from Utah, where he did his undergraduate degree in economics before he went on to UT Houston for medical school. We were fortunate to attract him to UC Davis for his general surgery residency. And I remember the day he came to me saying that he thought he wanted to be a pediatric surgeon, but he really didn't want to do basic science research, go through the sort of traditional path that people think you have to do to be a pediatric surgeon. And did I think it was possible for him to get into pediatric surgery without doing that? Of course, I was disappointed that not everyone in the world wants to work in my lab, but that's just actually not true. But I said, yes, I think you can. We would support you, and let's give it a try. That you shouldn't do something you don't want to do just because you think it's someone else's expectation, but you should follow your heart. And he was a great example of that. He went to Boston Children's, where he did a critical care fellowship in the middle of his general surgery training, and then surprised us all and stayed on another year because he actually got interested in doing some research and learning some of the techniques related to that. And because of the flexibility that we were able to accommodate that in our general surgery program, which is what we try to do all the time in all of our training programs, is really tailor the experience to what's best for you as a trainee. So he did match in pediatric surgery to actually his top choice program. He's going to be going to Florida, and he has an interesting life story that I think he's going to share with us today, and we are just proud that you proved us right, that you can follow your heart about a decision and still be successful. So Kyle, welcome.
Good morning, everyone. Thank you, Dr. Farmer, for the introduction. As she mentioned today, I want to speak about something that is very near and dear to my heart, and that has really changed who I've become throughout the course of my son's life. I have no disclosures. I wanted to start with a question, and that question is, what is the value of a human being? How is it measured? Is it based on intelligence? Is it based on wealth, skill, work ethic? Is it based on, or does the value change based on, race, gender, religious beliefs, neurodiversity? A term maybe not everybody's familiar with. An economist would say the value of a human life is $10 million. That's up $3 million from when I was an economics major. So we're all appreciating. I think there's a lot more to it than that. And what I want to propose is that value is inherent in all of us. It's part of being part of the human race, and it's what we are able to give to those around us, not in a monetary way, not in a measurable way, but I think we felt it most during COVID and when we weren't able to be around each other. And I would like to then start sort of in the beginning. For all of you who have children or know children or been around children or treat children, you all know that we don't choose who they are, but must learn to love them as they are. They're not like a fancy car or an accessory or even a dog. They are not something that we, show off to everybody, but they're unique, they're interesting, and have unlimited potential. And they are our future. In 2014, I was 28 at the time. My wife was 24. We were both in medical school. We were fourth-year medical students. And I, near the end of her pregnancy, we had a 2-year-old boy at the time, and then she was pregnant with our second one, who was going to be born about 2 years after the other one. I was away for basically the last 4 months of her pregnancy on away rotations, and she stayed back in Houston doing her rotations. She suffered through pneumonia. She had the second birthday of our boy. Had a lot of things that she was dealing with while I was, off trying to learn how to be a surgeon. And she convinced me to not go on my last away rotation and instead to come home. And I did, and then, within a couple weeks, actually, she went into labor. And she was 3 weeks early, and our baby was born. Now, when the baby was born, my wife and I looked at each other, and we said, is there something different? He looks a little different. And then, we would see, like, flashbacks of him, how he looks in this picture. And we said, no, there's probably nothing wrong. It's just, we're being silly. Thinking back to her pregnancy, she had to go in quite frequently because the baby's heart rate was pretty low. I think it was in the 120s, which is fairly low for a neonate, or really for a fetus. Now, and then they also noticed that he wasn't quite as active when she was pregnant. And so all of these sort of came flashing to our minds as we look at our son and we say, well, I don't know, his neck looks a little funny. And then again, we sort of brushed it off. Fast forward a few hours, we're now in the postpartum room, and my mother-in-law is there, and she says, I think he looks blue. I think you should get the nurse. And we said, no, he's not blue. You're just being a grandma. And she again says it, and like my mother-in-law is incredibly persistent. And so finally we said, okay, we'll get the nurse. And the nurse is like, yeah, he is kind of blue. Let's bring him to the nursery. So he gets brought to the nursery, and I go with him. My wife stayed back in the room. And so as I'm there, it's, now by this time about 7, 8 in the morning, and the neonatologist is making rounds. And he comes by, and he comes to our son, and he pauses. And then he starts looking over him. He, this is our baby Blue. Sorry, I forgot to show that. But then he starts describing certain physical features with pause and with a lot of, he was very gentle, and he said, your baby has hypotonia. He's got epicanthal folds. He's got low set ears. He starts describing some other things. He's got a single palmar crease. I was a fourth-year medical student, and I knew sort of immediately what he was alluding to. And then he said, look at his hands. His hands are a little different, too. They're kind of short. And I said, sir, I know what you're referring to. Are you suggesting he has Down syndrome? And he said, yeah, I think he does. And I didn't know what to think. I let him know, I want to go to my wife, and I want to tell her myself. And so I did, and we cried. And we were very sad. And, it had seemed like our whole world had been turned upside down. He had an older brother. His brother's life was going to be completely different. I could really only think of his older brother at the time. And I thought, well, he's not going to have the life that I lived. I was like thick as thieves with my brothers. And this is just not going to happen. And things seemed kind of dark. My wife and I told each other, though, if, there's nobody else that we would rather go through this with. I didn't really know what that meant at the time, but it sounded, like something that I should say and that we should say to each other. As the days moved on, like I said, I was sad, I was scared really of what would become of my family, what was going to change, how I couldn't picture now what our future was going to look like. Really, I was scared because my son wasn't going to be the Ferrari that I thought that he was going to be. He was going to be more like, my 1991 Volkswagen Vanagon. I was like, it's a great car, but is it really all that it's cracked up to be? And I didn't understand his value. I didn't understand his value in society, in the medical world. I didn't understand his value in my family and, his value as my son. And I today wanted to take, a little snapshot of his life as I discuss various aspects of the life of somebody with Down syndrome to show you really what their value is, so that if you have a son like mine, or if you meet patients who has kids like yours, or if one of your patients has Down syndrome, then you will know what they went through, and two, that they, like all of us, have the value of a human being. Just some basic statistics. A baby is born with Down syndrome about 1 in 700. That range is actually difficult to calculate because of the sort of increasing prevalence of early terminations in pregnancy. But currently, the birth rate actually is about 1 in 700. In the 1950s, only 27% of those living with Down syndrome were greater than 20 years old, and only 4% were greater than 40 years old. Now in 2010, flash forward about 60 years, 57% were greater than 20 years old, and 28% were greater than 40 years old. So a pretty substantial difference. My wife is young. She was only 24, and so on this graph that we've probably all seen, she was sort of over here in the flat part of the curve. Basically, no difference between had she had the baby as a teenager or as early as she could have it. And so another way to look at it, she was in this area. 1 in 1,000 chance of having pregnancy with Down syndrome, and about 1 in 1,400 chance of having a baby with Down syndrome. Not really that much different than somebody who was 18. Now you jump to 40 years old, 30 years old and 40 years old, the chance just astronomically increases. At the age of 40 is about 1 in 80, 1 out of every 80 children born to a 40-year-old woman would have Down syndrome. So that was sort of my introduction to Down syndrome. I knew a couple kids in high school, but I didn't really know them. But I wanted to bring us back about 150 years to this man, John Langdon Down, where the Down syndrome comes from. And you'll notice 2 different spellings. Sometimes people say Down syndrome, sometimes people say Downs with an apostrophe S. That's usually how they say it in England. And normally in America we say Down syndrome. He was really the first one. So he was born in 1828, in Cornwall. He was the son of a pharmacist, and at the age of 18, he had a really life-changing experience that I thought was really impactful. He describes that experience in his own words. He says, "I was brought into contact with a feeble-minded girl who waited on our party and for whom the question haunted me, could nothing for her be done? I had not yet entered on a medical student's career, but ever and anon the remembrance of that hapless girl presented itself to me, and I longed to do something for her kind." How many of us as surgeons, as scientists, have had this same thought? Is there nothing that can be done with that baby with long gap esophageal atresia? Is there nothing that can be done for this pancreatic cancer, for this breast cancer, colon cancer? He was a true scientist back in the 1800s, and he pursued his dream. Now, science was, maybe a little different then, but he began his journey as a pharmacist, son of the pharmacist, and then after his father's death, he went to medical school. Now, shortly after graduating from medical school, he was the leader of an asylum. They called it an asylum for idiots, and that was their term for those who were intellectually disabled. And it had 300 patients in it, and these were patients of all ages, primarily children, but there were, adults as well. And he was the only physician. So straight out of medical school for the third-year medical students, get ready. You are about to become the superintendent of an asylum for these children that we don't really know anything about. Now, he focused a lot of his work on what Blumenbach described as the classifications of the races of the world. And so, we didn't know very much about those who were intellectually disabled. And so what he tried to do is classify these individuals based on how they appeared to fit into a certain race. Now, at the time, 5 races were described. They described Mongolians, who were really from East or Central Asia, Americans, like Native Americans, Caucasians, Malayans, that was like Southeast Asia, Pacific Islands, and then Ethiopians who, were black. And that was like a very popular way to categorize people at the time. Now, again, this is in England in the mid-1800s. So he decided that he was going to classify all these intellectually disabled into these categories. And so his first sort of big famous paper, really what he's known for, is this Observations of an Ethnic Classification of Idiots. What's important and how he starts off this paper is he says the medical practitioner who may be consulted in any given case has perhaps in a very, very early condition of the child's life to give an opinion on points of vital importance as to the present condition and the probable future of the little one. Now, I think this probably applies more to pediatric surgery, which is maybe why I was drawn to the statement. But he goes on to say that there is a certain classification that he classified as a Mongolian type of idiocy. And he classified them as being more than 10% of those who are intellectually disabled. Now, what he described as Mongolian idiots were actually children with Down syndrome. And he described them as always congenital idiots, meaning, this was always something that happened during the mother's pregnancy. It was never a result of an accident after uterine life. And that was, he describes a very long, drawn-out portion of his paper as describing this, of ways, of different things that mothers would approach him with, saying, was this the medicine I took? Was this because of the accident that I had? Was this, all of these things? But then he goes on to describe physical features that echo in my ears of the neonatologist when my baby was born. Here's my son now. He's 7. He, and in Dr. Down's words, he described them as having a flat face and broad. He described them as the internal canthi more than a normal distant from each other. So, these are the internal canthi. You can't see that. These are the internal canthi. His face is sort of broad and flat. Sorry, I think he has a piece of grass on his tooth. He doesn't have a rotten tooth. He describes the tongue as long, thick, and roughened. The nose is small. He, describes their skin as a certain tint. He goes on to describe other aspects of facial features. If I could add, the low set ears, the widened nape of the neck. There are many things that my son has that fall into these categories that he described now 150 years ago, and sort of as the first one. So other things that he described of these, this classification of these intellectually disabled, that they have considerable powers of imitation. Now, if I can describe to you what my son is able to do, he will frequently, just repeat back the words that you say when you read him a book. And he's done it his whole life. And I hadn't really ever thought of it until I'm reading his paper. He'll do the same thing as you're saying a prayer, or as you're saying something, he will just vocalize the things that's being said. And sometimes it drives his siblings nuts. But they don't realize that that's really just part of who he is. And then he describes this: they are humorous, and a lively sense of the ridiculous often colors their mimicry. I have example after example of this with my own son. And then he says they are usually able to speak. The speech is thick and indistinct, but can be usually improved upon with tongue gymnastics. So Dr. Down was the first one really to describe having within this asylum for the intellectually disabled physical therapy, occupational therapy, speech therapy. And he found that he was able to really make a difference in these kids' lives. And if I could say that this tongue gymnastics is one of the most important things that I've seen in the life of not only my son, but in the lives of those who are also in the community. Those born in the 1950s, part of the reason they were dying, or that there was not a significant amount of them after the age of 20 or 40, was because they weren't learning these things and because they didn't know, even though Dr. Down had described these, 100 years prior to that. He also described their circulation as being feeble. My son, although very active, is very affected by the weather. If it's hot, if it's cold, he shuts down. And then he says their mental, just related to temperature. Now, So a couple important things about Dr. Down that I really enjoyed. And one is that he took this and he sort of ran with this concept of them being Mongolian in race. But he did it, I want to point out this last statement. He says, "I cannot but think that the observations which I have recorded are indications that the differences in the races are not specific but variable. These examples of the result of degeneracy among mankind appear to me to furnish some arguments in favor of the unity of the human species." And so he goes on to describe further on in the paper that this to him proved that we are all the same, that race didn't matter, that skin color didn't matter, that physical features didn't matter. And I echoing in my ears are words of Dr. Farmer that, skin color is only skin deep, and we as surgeons know that the best. Well, Dr. Down knew that also in the 1800s. Not a common sentiment at the time. Now, he was also an advocate for women's rights. At the time, higher education for women, they thought would produce feeble offspring, and so it was very much discouraged. He disagreed vehemently with that, and he was an advocate for women. And he also advocated for a paying position for his wife, which was also against sort of the standards of this center that he worked at, and it was to the point where he lost his job as he advocated for his wife. And then something that I'll touch upon a little later, but he closes his article by saying the improvement in those with Down syndrome, which training affects in them, is greatly in excess of what would be predicted if one did not know the characteristics of the type. And I can't emphasize to you how important this concept, in those who are intellectually disabled, in those especially with Down syndrome. Interestingly, after Down died, he had a grandson that was born with Down syndrome. What a legacy to him that he created this world that was better for those just like his grandson. Let's transition now back to, a little bit more with my son, so that we can go into a little bit more, what happened through his infancy. On November 28th, he was a month old, exactly a month. He contracted RSV. He got it from his older brother. And we were confident, parents, that we knew how to take care of a bronchiolitic kid. He was fine. He was doing fine. And our confidence sort of reminded me of the end of my second year of residency, when I was real confident that I knew how to take care of a sick patient in the ICU. Oh, they're fine. But I didn't realize the things that I didn't know. He became lethargic throughout the day, but he was still responsive, so we were encouraged. Again, at the nagging of my mother-in-law, we decided to take him in, because at this point he truly was lethargic. It looked like he was breathing hard. When we got to the ER, they did not even bring us out of line. They brought us not to a triage area, but directly to an ER room, because they could recognize that he was sick. They immediately put him on oxygen, and after he was put on oxygen, they immediately upgraded him to high-flow nasal cannula, and this is sort of when he was initially put on. He, as you can see, is already working pretty hard to breathe, but he was also breathing intermittently. He was already to the point of starting to tire out. And shortly after, the ER physician came into the room and he said, your son is very sick and your son needs to be intubated. And, the walls came down at that point. I thought, wow, I failed. Here is my son that now I've really learned to love in the month that he was born. And what did we do? We sat at home all day while he, escalated, needing to be intubated within an hour of us getting to the ER. And I can't even remember if the physician was a man or a woman. My wife tells me she was a woman, because, at that point, everything changed. And I just, it was a blur. Now, the next 2 weeks were a blur. I remember staring at the monitors just like I see parents do. I remember staring at the ventilator and saying, oh, look, there's a breath. There's a breath. I didn't really know what I was looking at. I'd never taken care of a ventilated patient. And then I remember the day that he was extubated, I was so elated. I was ecstatic. And then, 3 hours later, he failed extubation and had to be reintubated. And again, the walls sort of came crashing down. And but he did better, and he got better. He got steroids the second time. He was ultimately extubated. Here's just a little video that I thought was very pertinent. This is, as he's ready to get extubated, he is ready to start putting something in his mouth. The next couple of years were harder for him. He, had significant residual lung disease from that. He required oxygen going home. He was in the hospital that first day about 17 days. And then he went right back to the ICU, right back on high flow about 2 weeks after that, as he either, had a new virus or just decompensated at home again. Now, to put this into context, I was a fourth-year medical student, and this is in November. So this is all throughout my interview season of general surgery. And in fact, between the time he was born, so he was also in the NICU when he was born. He was on oxygen then. He had pulmonary hypertension, and that eventually resolved. He had a small ASD, but that has since closed. But he, right after he left the NICU, 2 days later, I actually interviewed here at UC Davis. And then, 2 weeks later is when he went into the PICU for the first time. The remainder of that year, he, would go to the ER multiple times, maybe 10 times or a dozen times, and then was admitted again at 2 years old. I was on trauma call that night. He and my now newborn, 28-day-old, both had influenza, and they were both admitted. Sarah Park kindly offered to have Andres watch my other son, but I didn't know Andres at the time. Had I known him, I maybe would have taken her up. I thought it was a weird offer, but he required oxygen for about the next 18 months. His right upper lobe was down for really that whole year. Every repeat X-ray that we got, it was still collapsed, and we thought maybe it would stay collapsed forever, but it eventually opened up. But he did require oxygen, and it's amazing the amount of grief that oxygen cost. He had a pulse ox at night, and that thing would go off, and it was like your pager going off right in your ear. You'd jump out of bed thinking that the world was falling down, and really it just come off of his finger or whatever. But then we needed oxygen also when we went to altitude. Anytime we drove up over the pass in Tahoe, if we were driving home, he would need oxygen literally on the pass as we got up to oxygen. And then he would need it the whole time in Utah, the whole time in Colorado. And that begs the question of should we have been traveling with him? It's probably not, but we did. We'd have to bring an oxygen concentrator with him on airplanes because he would need it then too. And he needed it until about 18 months. After that, he still needed yearly specialties, or yearly follow-ups with specialists, audiology, ENT ophthalmology, cardiology, and pulmonology. He had yearly developmental evaluations. Some of these were biannual. He had endocrine visits, and then visits to GI. And really, most of it was preventative. But he had a lot of visits. And I want to remind you that he is for the most part, a healthy boy with Down syndrome, even though he was in the NICU and in the PICU. Let alone the amount of therapies that he needed. Speech therapy, music therapy, physical therapy, occupational therapy, feeding therapy, water therapy. He would get these, upwards of 10 hours a week. They would come over to our home. If I go back to my wife, she was a fourth-year medical student also. She graduated. But she stayed home because of the birth of our son. And it was to accomplish these things. She couldn't leave these in the hands of somebody else. He wouldn't, progress in the way that Dr. Down had mentioned, only with significant work. They came to our home until about age 3, and then that transitioned over to sort of school-age things. But what if he'd had congenital heart disease? What if he'd had Hirschsprung disease or an anorectal malformation, duodenal atresia? All of these are common in Down syndrome. What would his life have been those first 2 years? If you look at costs, from just even a hospitalization standpoint, 75% of infants with Down syndrome get admitted to the hospital that first year, compared to only 16% of infants without. They have 3 to 4 times higher average outpatient visits also. Now you could see that even in the list that I just showed. And then costs in the first year of life overall, and this is including those with congenital heart disease, that their cost is on average about $78,000 compared to $12,000 for a normal child. And then, average costs are about $33,000 a year for the first 4 years of life compared to $10,000. About 50% of them have a congenital heart defect that requires intervention. Now, the median costs for infants without a congenital heart defect is 5 times higher, and it's 20 times higher if you have that congenital heart defect. And if you average those together, it's about 12 to 13 times higher. And so, it begs the question, are the medical costs worth it? Here is a boy that we don't really know what his outcome's going to be. And we don't know how he's going to function in society. For my son, the answer is a resounding yes. I want to go through just a couple videos of his progression of walking and the amount of therapy that he did need. And so the first thing that he needed was, help with walking. That was the big milestone that needed to be accomplished. If he could walk, his life was going to be okay. And physical therapists out of Sac State are the ones that have this free program that they would walk with him on a treadmill. And here's sort of a picture of him as they're working with him on this treadmill. And again, my wife would go to all of these. This is twice a week for an hour at a time. This is the sort of his next step in walking, is they gave him a walker. And with this walker, he learned to walk with it. And he did, quite well. He still didn't have the core strength to be able to walk, but he did. This is him at about 18 months.
You gonna help him?
There's sort of his older brother helping, and
sure
I might add was helpful sort of from the beginning, becoming best of friends. And then finally on his second birthday at a Halloween party that we went to is the first time that he took his first steps. And there is actually my mother-in-law, the infamous mother-in-law, and this is a costume she had made. But because of the walker that he had, because of the treadmill, they're all reasons that, made it so he could walk. And then, his next step was, in my wife and I's mind was, the only thing that I want him to be able to physically do by the end of his life is to be able to ride a bike. And that's what we told the physical therapists. And at this point, physical therapy was sort of phasing out for him. He could walk. He could do most things that normal kids could do. But they worked now for the next 3 years on trying to teach him coordination to pedal. Now, obviously, a 3-year-old, most 3-year-olds don't ride a bike, but starting at 3 is when he started. And then to this sort of monumental day for us when he was 5 years old, just over 5, we got him on a pedal bike. Now, this is after several years of being on a balance bike, if anyone's familiar with those. And this was, I can't describe to you the elation and the joy at this point. And, he struggled a little bit still. And mainly what he struggled with was the coordination of pedaling. He actually had the balance down very well. It's that older brother again.
You're doing so good.
So, the videos are cute and they're great, but what I want to focus on next is, that we just went through several things that the medical community provided for him and provided for us as a family. But is there something that they then can provide as a community of individuals with Down syndrome that to where they can contribute to our society at large? And the answer to that is also yes. they are in a very unique position as individuals where diseases happen with, a curious frequency in them. The first one is Alzheimer's disease. Now, Alzheimer's in individuals with Down syndrome happens in 90% of individuals by the age of 55. Now, we only know this now because they're living beyond that. And they essentially all get it. If they happen to have it by 55, they probably have it by 60. That's compared to 12% in the general population, so pretty astronomically high comparatively. Now, the reason for that has been chalked up to this APP gene that's on chromosome 21, which is, the trisomy in Down syndrome, trisomy 21. So they have 3 copies of chromosome 21, and they make this gene that cleaves amyloid, and then the amyloid builds up as amyloid plaques in the brain. Now, there's other causes for Alzheimer's. One is this tau protein that's shown here on the left. But that one, they actually don't develop Alzheimer's because of that. They develop it because of these amyloid plaques. So how does Down syndrome help solve these sort of bigger questions in Alzheimer's? Well, there, first of all, is a predictable timing of onset. For anybody familiar with Alzheimer's disease, it can happen sort of at any time, and 12% by age 65 doesn't sound like great odds for a randomized control trial. And so the trials that they've had are if they have mild symptoms of dementia, but that could progress really quickly, or they may not, be able to get enrolled in the trial at that point. And so they have individuals with Down syndrome hold a key to potentially establishing really a durable therapy to fight this disease that plagues so many of Americans and individuals at large throughout the world. Part of the other issues with these Alzheimer's trials is they don't know when it will happen. They don't know sort of the age of onset. They don't know who it's going to happen among. But in those with Down syndrome, they do, because it's basically everybody. Now, they have been traditionally excluded in clinical trials, and I mean for obvious reasons. They're a vulnerable group. They're not a group that we want to take advantage of. And that's most likely the reason why it's not been utilized in the past. Other reasons are, it would require a separate arm in studies. It's like maybe the funding's not available, all of these reasons. But brought to light in an article in the Washington Post actually about 3 weeks ago was this article about Alzheimer's research and Down syndrome. And in the article, they talk about this therapy, and this therapy is called Aduhelm or aducanumab, which, to be honest, is not even necessarily a great drug in those who in preventing Alzheimer's, but it was shown in clinical trials to decrease the amount of the plaque burden, but didn't really have any clinical results. But the article points out that maybe it would in Down syndrome. We don't know because they're excluded in the trial. But I wanted to show a video of a man named Frank Stevens who has Down syndrome. He's a big advocate for those with Down syndrome in the field, and he's speaking here before Congress as an advocate for individuals with Down syndrome. You'll have to forgive me because it is. I have to drag it over in order to watch the video.
Budget. On a deeply personal note, I cannot tell you how much it means to me that my extra chromosome might lead to the answer to Alzheimer's. It's likely that this thief will one day steal my memories, my very life from me. This is very hard for me to say, but it has already begun to steal my mom from me. Please, think about all those people you love, the way I love my mom. Help us make this difference. If not for me and my mom, then for you and the ones you love. Fund this research. Let's be America. not Iceland or Denmark. Let's pursue answers, not final solutions. Let's be America. Let's make our goal to be Alzheimer's free, not Down syndrome free. Thank you.
Sorry, let me bring you back to so, there are many others like him who are big advocates for those in the field of Down syndrome. I'm sorry, give me 1 second. My notes sort of disappeared. I apologize. Let me just see if I can get this up back up. Okay, sorry about that. So in addition to Alzheimer's, there are many other areas also that is unique to Down syndrome. One is, in both solid and liquid tumors. They have a 10 to 20-fold increase in developing ALL and AML. They don't respond well to therapies, and the therapies, they reach toxic levels at a much earlier level. But then there's a certain subtype of AML called AMKL that has a 500-fold increase in developing in Down syndrome. And, the interesting thing about AMKL is, nearly 10% of newborns with Down syndrome are diagnosed with it. But their event-free survivals from this certain variant ranges from 80 to 100%. Some of them even spontaneously resolve. And if you compare that to normal children, that's compared to a less than 30% event-free survival. So it's very... it is a pretty substantial difference from basically everybody getting cured to less than a third of individuals surviving. And it's thought to be due to this GATA1 mutation, which is on the X chromosome. This GATA1 mutation both causes leukemogenesis, or the developing of their leukemia, but it also seems to contribute to their high cure rates as well. But clearly we don't understand all the nuances of that, and that is one area that could be targeted for future therapies. And then looking at solid tumors is pretty miraculous. Out of a database of 54 million children in Europe, 2,700 were found to have neuroblastoma and 0 had Down syndrome. In a national Wilms tumor database, out of 5,800 individuals, this is in the United States, no children with Down syndrome were identified. There have been case reports, but that's it. Now, you compare that to trisomy 18, 13, or some other genetic abnormalities, and they have an increased propensity to developing Wilms. And then breast cancer also. In a Danish sort of cancer registry, there were 0 individuals with Down syndrome that had breast cancer. Now, there's multiple genes that may be contributing to this that they are currently studying in both like murine and human neuroblastoma cells. This is this like S100B protein that's on the 21st chromosome, or there's other genes located on the 21st chromosome that may be sort of the reason for that. But it may not be, just like the GATA1 mutation. That's not on the 21st chromosome, but for some reason there's a higher propensity of mutations. And then there's other genes also that they're studying. Other sort of genetic propensities are with autoimmune diseases, and again, there are genes that are identified on the 21st chromosome that have made a big difference there, and they could be areas of study. What is UC Davis doing? UC Davis actually has 5 current studies ongoing to investigate Down syndrome. Now, this is Down syndrome research and not necessarily translatable to typical children or typically developing children. But there are studies on ADHD and medication. There are studies where they are looking for accurate tools to measure their cognitive development or their cognitive decline that could be used in Alzheimer's again, in addition to some others. All of these are current studies at the UC Davis Mind Institute. Christopher's been involved in one, and then they've reached out to be involved in others, and we were unable to participate. There are also other foundations or organizations, the Lou Mind Institute, Linda Cernick Institute. UC San Diego's research is, I think, the most fascinating and impressive, where they are looking at mouse models to look at the deficiency in neurogenesis in Down syndrome. One, to help correct it among individuals with Down syndrome, but also to be able to apply broadly across all neurodevelopmental problems, or even in sort of brain trauma and different things. And they're also looking at different vaccines for Alzheimer's disease. There's a lot of research going on right now. And the scientists out of San Diego are very inspiring, and they've made great progress. As we go back and focus a little bit on Christopher again, as he is now out of those neonatal years, new challenges present themselves, challenges with friends, school, sports activities, social activities. His reliance on the medical system has decreased, but all of these things have, come to the forefront of his everyday life. As he's progressed, from his bike previously, he's now feels very comfortable even on a bigger bike, and can get on and off of it on his own, which took even another couple years. We've been very adamant that he skis with his brother and sister, and it was to the point where when we would ski, he would literally fall asleep while he was skiing. And I kid you not, he would hold on to this hockey stick and he would fall asleep, and then you'd lay him down and he'd literally be asleep because of the exhaustion that it would cause him and the cold. But here's just a brief little video of him sort of skiing. And there's like a faint sound of music playing, and that's because he will only ski with music. But he's gotten better and better, and every year he goes on sort of more and more difficult runs. And then, integrating into the community, this year was the first time he's ever been on a sports team. And it's been a huge learning experience for him, for us, for his team, and the patience his team requires. But as we sort of, the reason I bring up those aspects is because as we move out of the medical world and into family community, the question still remains, what do they have to contribute to us, and what can we contribute to them in terms of individuals with Down syndrome versus not Down syndrome? I go back, I want to start with family and just say, back to my initial fears. How is this going to affect me? How is this going to affect my family? Were my fears valid? I showed these two pictures because this picture on the left is a ski trip that we took cross-country skiing in the middle of Maine. And so, he had medical problems as a child or as a baby, but now those are no longer a worry for us. He can go and do hard things. We were 7 miles from any, close even vehicle or car. We skied to these cabins without electricity, and he was there the whole way. He did the same thing as as his siblings. And this is sort of where he falls in the lineup of my family. These are our children. That Jimmy is the oldest at 9. He's 7, and then his little sister's 5. And then now he and the youngest are our best of friends, but they are all close friends. Is this true across all families? Do they provide this support? Do they provide, something different, unique, that is helping with families? And, this study I just wanted to briefly highlight, they looked at divorce rates in families of children with Down syndrome versus not Down syndrome. And, there were problems in the study. But there were a lot of families that they looked at, and they did find that families of individuals with Down syndrome had a lower divorce rate. they had a divorce rate of 7.6% compared to 10.8% in families without any developmental disabilities. And that was compared to an even higher divorce rate in those with other birth defects. And those included a whole host of birth defects, including musculoskeletal, congenital heart, other intellectual disabilities. That same author wrote another paper to try to describe maybe what was the cause of this. And it's something that's been now coined as the Down syndrome advantage. And you'll see that in newspapers, you'll see that in papers. But it's been studied a lot. Most of the studies were out of the 60s, 70s, 80s, and 90s. And then there's some in the early 2000s, like the last study that I pointed out in this one. But there hasn't been as many recently. The research has really transitioned over more to autism. But he describes things that we've found in our family. Christopher has an emotional maturity that is unrivaled by his siblings. He has, a lot of behavioral problems, there's no doubt. But he is emotionally aware of people's needs around him. When his brother's crying and needs something, he'll be the first one to bring a bottle or like a stuffed animal. When his mom is having a hard day, he recognizes it, and he is able to change sort of his tune and his behavior and give her the physical support that she needs. There's very little arguing between he and his older brother and he and his younger sister. But then it works sort of the opposite way as well. His siblings look out for him. They try to include him in activities with the neighborhood kids. The neighborhood kids now are not scared of him, which at first they were because he was different. And now they think of him as Christopher and as their friend. And he will now go to their houses sometimes, on his own, which is not to the liking of his parents. But this article attempts to quantify that, and I think just speaking of Christopher was maybe a little bit more useful. I just wanted to show a couple more videos sort of to close as we talk about this Down syndrome advantage. Because this advantage does apply to schools. It applies to sports teams. It applies to workplaces. And I wanted to, if I can do it maybe a little bit more elegantly this time.
Hi, my name is Nicole.
My name is Melissa.
My name is Philip A. Donahue.
My name is Nina Dudias.
Hi, my name is Scarlett Reedy. I work for the Boston Boys in Kindergarten.
I come to work every day with a smile on my face.
Smile on my face every day.
I have a positive attitude.
Great positive attitude.
I always on time to work.
All the time.
I don't fake being sick.
I don't quit.
I have worked at the State House for 3 years.
10 años.
I've been working here for 5 years.
13 years.
19 years.
I love my job.
I love my job.
I love your job. Yes, I do love my job.
That's definitely true.
I worked hard at school.
I know how to listen.
I know how to overcome challenges.
I've done my whole life.
Having someone in your office with Down syndrome can make a whole lot of difference.
Make it better. For coworkers and customers, I may need more time to know the job,
Extra support.
Extra tools.
but those are easy to find.
And the rewards will worth it.
Yeah, it is worth it.
It's worth it all the way.
A lot of people just come to the grocery store to get groceries, but Phil makes it more of an experience. If he's not bagging on a register, where'd Phil go? If he's on break, they're questioning it. They notice. Phil likes to take care of the customer and make sure that we always remember that.
It's absolutely important in today's world to have a diverse workforce because our society is diverse. When you have people that have a positive attitude, that like coming to work, it's contagious. Nicole is one of our leaders when it comes to that.
The thing that I always say about Melissa is Melissa has become my ambassador. not only does she take the job very seriously and is very committed to helping the constituents I represent, but she's really there to help anyone.
As soon as John walks into the building, everybody's mood instantly changes. I think John is one of our most valuable employees. I'm proud to call him my co-worker. It's good work.
That's a good word, Bob.
We love working with Lena, and she does a good job.
Great job.
Thank you.
Thank you.
So if you value hard work,
Hard work,
We prepare diversity.
reliability.
stability,
Honesty.
here I am.
Here I am.
Here I am.
Here.
I'm ready for work.
So I know I'm basically out of time, and I just wanted to end on sort of a few notes, if I can. Down syndrome in my life has really changed the way I view people, that I view people with, who are neurodiverse, but also every individual. I wanted to highlight, who my son was and that he lives a full life as an individual, that he will be a positive contributor to society, to his family, to, his sports teams, to his workforce in the future. At Boston Children's, there was their first full-time employee is a man named Nate, who has Down syndrome, their first full-time individual with Down syndrome, worked in their Down syndrome clinic, and I would see him every day, and I would, sneak onto the elevator so I could talk to him, and I would walk with him at the end of the day to really see what he was like and who he was. And he had a normal life. He lived on his own. He had a girlfriend that he was hoping to get married to. He had likes and dislikes, but he was contagiously positive. And I would say, my son has ups and downs. He's positive, he's negative, he can be very challenging, but overall brings this sense of love to our home that it would not be there if he was not there. I just want to end with this one video of that same man, Tom, or I'm sorry, Frank Stevens. I want to show you what he says.
Mr. Chairman.
And I want to echo these words. So this is him speaking to Congress.
And members of the committee. Just so there is no confusion, let me say that I am not a research scientist. However, no one knows more about life with Down syndrome than I do. Whatever you learn today, please remember this. I am a man with Down syndrome, and my life is worth living.
Sorry for the back and forth. With that, I would like to end. I think his words say it best. Their lives are worth living. And he has brought an immense amount of joy to me and my family, joy that is beyond anything that I could describe in a presentation, and that I know he will do the same and does the same for everybody around him, for his friends, for his school, for his teacher, and for everybody who interacts with him. He's very contagious. And with that, I would like to thank everybody who's, been with me the last 7 years. It is almost a decade, feels maybe longer. But But I would especially like to thank my wife, Kina, who has supported me through all of this and is supporting me still to go down to Florida. I would like to thank, my mentors at Boston Children's. I would like to thank Dr. Salcedo and Dr. Farmer. The pediatric surgery division, the trauma division here, I always considered them sort of my first home and first family. And, obviously all of the support staff that helps us accomplish what we are here to accomplish. And with that, I'll end.
Kyle, I just want to thank you for sharing that deeply personal and incredibly moving and educational experience for all of us, for diversity, for tolerance, for love, for all the things that Christopher and you have represented in terms of how you manage your life with challenges. So for all of us who think, we've got some problem today, a lot of this puts it into perspective. So thank you for that. We wish you all the best in your next adventure. We'll be looking forward to seeing how this goes. I don't know what I think about Florida and the heat, but for that decision, but I think I speak for everyone that you moved us all tremendously today, and thank you for that in so many ways. Does anyone have a question? It's really hard to, Jonathan, Dr. Coley.
Kyle, thank you. I think that was an amazing, wonderful talk, and as the father of another neurodiverse kid, just so important to remind us all the value of these kids, and the value of nothing about us without us, right? Like trying to engage patients. And I guess that's my question. In your own practice and in all of our practice, how can we do a better job of engaging these patients in their care decisions? Because they are, for us, they're children, but for most of the people here, when they encounter someone with Down syndrome, it's going to be as an autonomous adult. And how do we remember, and how can we help guide our conversations with these patients to engage them in care decisions?
I think that's a really great question. There was a movie recently out with Shia LaBeouf, and about an individual with Down syndrome. And now I'm, going to blank on the name right now. But in the movie, the Peanut Butter Falcon. Thank you, Peanut Butter Falcon. And in the movie, I think it represented the ideal way to interact with those with special needs. And that is to treat them like you treat everybody. And that is, you speak to them like they are a real individual. You include them in their care as if they can and do understand you, because they do. And, so much of when I speak to my son, I still think, because he doesn't necessarily register it when I first say it to him, he'll bring it up to me the next day, or he'll remind me that I promised him this, this, and this. And so I think the thing that I would say is they understand way more than sometimes they give off the impression of. And I think that's probably true of most individuals with special needs. I can say that for surely true of Down syndrome. And they understand both hurtful and positive things. And so I would say just to keep that in mind as you speak to them.
Well, thank you again, and really a spectacular adventure you have ahead of you.